Hello, everyone. Welcome back to my channel. This is Dr. Jennifer Teal here, and today I bring you a discussion on the official guidelines for coding and reporting for ICD-10-PCS. One thing I want to mention is to make sure that you're always using the current version that is in place at the time of the procedure that actually took place. So these usually start on October 1st of the year and go through September 30th. Most of the time with the official guidelines, there aren't significant changes throughout the entire guidelines every single year. So it's not like they're all replaced, but there might be some additions or some minor revisions. So it's always important to make sure you're looking at the current version. Your ICD-10-PCS code book should have a complete copy of the guidelines within it, either in the front of the book or in the back in one of the appendices. You can always obtain a PDF version as well if you go on the internet and use any kind of search engine of your choice and just search for the ICD-10-PCS official guidelines for coding and reporting. And you can find a version such as what I'm showing here on the screen. I obtained this from the CMS website, but it's a nice handy PDF version that I can have available. The beginning section is just some information about the guidelines, how they were developed, the cooperating parties who developed the guidelines. So that is the American Hospital Association, the American Health Information Management Association, CMS, and also NCHS. They partner together to come up with these guidelines. These are the rules of the road when you're doing your PCS coding. They accompany the official conventions within the code book itself, and you must always follow these guidelines. Guidelines sometimes provide sequencing instructions. They will tell you when to use one type of root operation over another and that sort of thing. So I'm just going to walk through these guidelines with you so that you understand how to utilize them and what they encompass. As a new coder, I would recommend that you at least take the time to read through them in their entirety only at least one time. So take the time to at least review them one time from front to back. This PDF is only 19 pages, so you can see that they're not too awful long, so it shouldn't take you too long to read through them. But the reason that I suggest that is because you need to know what types of things are covered in the guidelines. That way you can remember to refer back to them when you're coding a scenario that would fit that particular guideline, if that makes sense. So let me scroll down a little bit here and go to the next page. So this is the table of the contents for the guidelines. You have your main coding conventions. That's going to be section A of the guidelines. Then you have the medical and surgical section guidelines. That's going to be all your section B guidelines. You have obstetric guidelines that are going to be in section C. Radiation therapy is in D, new technology is in E, and then selection of the principal procedure is in F. The coding conventions for ICD-10-PCS, guideline A1 simply says that the codes are comprised of 7 characters. So every character represents something different. So your first character, for example, is your section. What section are you in? Are you in the medical surgical section? Are you in the obstetrics section? And so on. So we have section, then we have body system, then we have root operation, then we have body part, and so on. Always 7 characters long, okay? So within a defined code range, a character has that same meaning from each section to section to section, right? So character 3 is always the root operation in the medical surgical section. You're not going to go to a different table and have it have a different meaning. A2 says one of 34 possible values can be assigned to each axis of the classification. And this gives you the reminder that the characters I and O So the letter I, the letter O are not used in PCS so as not to confuse them with the number 1 and 0. So you have all of your 0 through 9, and then you have all of the alphabet A through Z except for the I and O. So the combination of the letters and numbers is what constitutes an ICD-10-PCS code. Values can be added as needed. So ICD-10-PCS, one of the great things about it is it leaves a lot of room for expansion because not every character is used in every single table. So not every particular root operation is going to have the same character values. So when something changes or comes up new, there's room within the classification system to go ahead and add that value. So it's expandable. As with words in their context, the meaning of a single value is a combination of its access of classification and any preceding values which it may be dependent on. So for example, the meaning of a body part value in the medical surgical section is always dependent on the body system value. The body part value 0 in the central nervous body system specifies brain, and the body part value 0 in the peripheral nervous body system specifies cervical plexus. So what that means is a 0 isn't just a 0. It doesn't mean the same thing throughout. It depends on where you're at within the code set. So that body part value 0 means one thing in one body system and something else in another body system. So you have to take a look at everything together to know where you're at. As the system is expanded to become increasingly detailed, more values would depend on preceding values. So for example, in the lower joints body system, the device value 3 in the root operation insertion specifies infusion device, and device value 3 in the root operation replacement specifies ceramic synthetic substitute. So again, you have to know where you're at. So that value, I would not worry about trying to remember these character values. Don't try to memorize the values. The ones that are going to be common to you are the sections, because you're going to know that everything in the medical surgical section begins with the first character 0. 0 represents medical surgical section. 1 represents obstetrics section. So you might start to remember the character meaning for that first character in terms of what section you're in. You might also remember the character value for your operative approaches, because there's only a few operative approaches and that character value doesn't change. So you might start remembering that X is external, for example. But the rest of the values, don't try to remember them because their meaning varies depending on where you're at, depending on what body system you're in, depending on what section you're in. So that value of 3 may take on a different meaning depending on where you're at. Next, we have a guideline about the index. So the purpose of the index is your starting place. That helps you figure out what table you're going to go over to. So it helps you, it has the information necessary to lead you to the table, and then the table is where you complete your code. That's where you, what we call, build a code or construct your procedure code. The index is not mandatory, but it is a good starting place. The tables are absolutely mandatory. So you always must go to the tables to find your valid code values. So always verify in the tables, even if the index provides you 3, 4, 5, 6, 7 characters, you're still going to go over to the tables, look at those character values, look at their meaning within that particular table, and make sure it fits your scenario. And what I just mentioned, here is the actual guideline that says it is not required to consult the index first. So you can go directly to the tables. In an instance like the medical surgical section, that is a huge section, and that is probably 90% of where your coding is going to come from. So trying to go directly to the tables for that section is probably going to be challenging. I would recommend you always use the index for med-surg coding. However, if you look at another section such as obstetrics, there's only a few tables in the obstetrics section. So that might be a great example of when it would be easier to go right on to the tables and look for what you're looking for versus starting in the index. So the guidelines give you the option of using the index or not using the index. Guideline A8 tells us that all 7 characters must be specified to be a valid code. So you must always have a full 7 characters, no more, no less. If you have less than 7, it's not valid. If the documentation is incomplete and you're not able to select the appropriate value for a specific character, then you must query the provider, because again, you have to have all 7 characters. Within the tables, valid codes include all combinations of choices in characters 4 through 7 contained in the same row. So this means stay in your lane. The first 3 characters are always going to be up at the top of the table, as you can see here, and then you build the rest of your code by selecting a character value for your 4th, 5th, 6th, and 7th characters. So this guideline here gives you the example that 0, J, H, so that's the first 3 characters up at the top, and then T, which comes in this bottom row, 3 also in the bottom row, V in the bottom row, and Z in the bottom row. That is a valid code because all of these characters come from the same row of the table. However, if we tried to do 0, J, H, W, which is in the top row, 3, which is in the top row, V, which is in the bottom row, that makes it invalid. We can't jump rows like that. So since we're using W as our 4th character right here, we have to stick with that row because there's no W in this bottom row. Okay, there's no W, subcutaneous tissue and fascia of the lower extremity. There's no W down here. So if we really needed infusion pump, then maybe we don't have the right body part. Stay in the same row. Your code has to come from one row in the table only. One word of caution there is sometimes the same character, the same body part might be represented in multiple rows. So you have to pay attention to figure out which row would be the correct row then to be in for all of your characters. And sometimes there are things like device that might be your deciding factor. Maybe the device that you're looking for is in this row, but not in this row. And that will help you determine which row you need to stay in. But always, always, always make sure you stay in your lane. So you have to build your code from one single row. No crossing lanes and going from one row to the next. Our next guideline is about the term and. Whenever you see and in a code description, that could be used to mean and or. Okay, so either one of those. The exception is when it's used to describe a combination of multiple body parts for which separate values exist for each body part. So lower arm and wrist muscle means lower arm and or wrist muscle. Okay, so and in PCS can be translated to either and or. Many of the terms used to construct PCS codes are defined within the system. It is the coder's responsibility to determine what the documentation in the medical record equates to in the PCS definitions. So this is one of the most important guidelines, really. It's telling you that as a coder, it is your job, basically, to read through the documentation and translate that into PCS terminology. The physician is not expected to use the terms used in PCS. So as a coder, it is your responsibility. You have to take your understanding of PCS and its terminology and its definitions and apply that to what is documented in the medical record. You have to do that translation. So you have to correlate what the provider says to PCS terms. So a great example, the difference between excision and resection, they are very similar root operations. Excision is taking out a portion of a body part, whereas a resection is taking out all of a body part. So if the provider documents a partial resection, you don't need to query the provider. You can use your knowledge of terminology and the definitions of PCS, and you can independently correlate that a partial resection means the root operation excision, because that means they took a portion out, not all. So a partial resection would fit the definition of excision. So again, as a coder, it's your responsibility to make that translation. They're not required, the providers are not required to use the same terminology. So that's all of the Section A guidelines, and that covers, those guidelines are applicable to all sections of PCS. They're the basic coding conventions, meaning the basic things that you have to use in order to code accurately. And then we get into section specific coding guidelines. So Section B is your medical and surgical section guidelines. So we don't have a, let's see here, make sure I didn't miss anything. We went from A11 to B2. So there isn't a B1. B2 is body system. And I'm not going to read through all of these. Again, I want you to read them cover to cover to make sure that you're aware of what is in here. So section B2 covers the body system. There's some general guidelines there with some examples. And then B3 is the root operations. Again, we have some general guidelines, but with root operations, we also have some more descriptive guidelines as well. So some more specific. This one on multiple procedures is important because it tells you under what circumstances is it appropriate to use more than one PCS code. So if during the same operative episode, the root operation is performed, the same root operation is performed on different body parts as defined by distinct values, then it's okay to code multiple procedures. So for example, if they did an excision of a kidney and excision of a portion of a lung, right? That's two different distinct body parts. So you have that kidney biopsy and lung biopsy, two different body parts. It would be appropriate to assign two codes. If you repeat the same operation in multiple body parts, and again, those body parts have distinct values. Example, excision of the sartorius muscle and excision of the gracilis muscle are both included in the same body part value in PCS. So in PCS, it would be upper leg muscle. That's how it's defined in PCS. So you would code multiple procedures because they actually did that excision on two different muscles, right? The gracilis muscle and the sartorius muscle. So it would be appropriate to use multiple procedures. So again, read through that. Here we have discontinued or incomplete procedures. If the intended procedure is discontinued or not completed, you're going to code the procedure to the root operation that was performed. So to the extent that they were able to get to. So if it's discontinued before any other root operation is performed, then you're going to code that as an inspection. Example, a planned aortic valve replacement is discontinued after initial thoracotomy and before any incision is made into the heart muscle. So basically they opened the chest up, but they didn't get any further than that. The patient became unstable and they had to discontinue the procedure. So that's going to be an open inspection of the mediastinum because they did cut them open. So that's why it's an open inspection. Our next guideline is on biopsy procedures, and this basically tells you that your qualifier value, anytime you have a biopsy, your qualifier value is going to be diagnostic. And this applies to excision, extraction, or drainage. The qualifier is going to be diagnostic. So a fine needle aspiration of fluid in the lung, they're going to send that fluid over to pathology to try and determine what the diagnosis is. So your qualifier value is going to be diagnostic. If you have a biopsy and then they do more definitive treatment, such as destruction of a lesion, excision, or resection at the same procedure site, then you're going to code both the biopsy and the more definitive treatment. So that's going to be multiple procedure codes. In the case where you have overlapping body layers in root operations such as excision, extraction, repair, or inspection, if those are performed on overlapping layers, then the body part specifying the deepest layer is coded, so the furthest that they went. So excisional debridement that includes the skin and the subcutaneous tissue and muscle, then you're going to code that to the muscle body part, so the furthest layer. Bypass procedures are coded identifying the body part that's bypassed from, and then the body part bypassed to. But a word of caution, we have two separate guidelines here because the coronary bypass procedures are coded differently. So B3.6A applies to all other bypass procedures, and B3.6 applies specifically to coronary artery bypass procedures. And the difference is that identification of the body part. So other procedures, other areas, not the coronary arteries, identify the body part bypassed from and the body part bypassed to. So the fourth character is the body part bypassed from, and then the qualifier tells you where it was bypassed to. But with coronary arteries, it says rather than identifying the body part bypassed from, that fourth character body part value identifies the number of coronary arteries bypassed to. And then the qualifier is what identifies the vessel that's bypassed from. So it's almost in reverse. I'm going to scroll a little bit more. So controlled versus more specific root operations. This has to do with stopping post-procedural or other acute bleeding. Control is only coded when the procedure that achieves the control is there's no other, it's not described by a more specific root operation. So if they do something more specific in order to control the bleeding, so like they do an excision, they do an extraction, something like that, you're going to code that more definitive procedure instead of control. Excision versus resection. And we talked a little bit about that, that partial versus all, part of a body part versus all of a body part. And so this is the guideline that tells you in order to make that determination, we're talking about the specific body part or subdivisions of body parts that are defined within PCS. So PCS gives the lobes of the lung their own body part. Regions of the intestines have their own body part value. So you have to look at, did they do a complete removal or a partial removal of that particular body part as reflected in its own unique character value in PCS. So the example is the left upper lung lobectomy is coded to resection of the upper lung lobe left, because in the body part value, when you're in the tables for that fourth character value, there is a separate value for upper lobe lung left. So if they do a complete removal of that lobe, it would be a resection, even though that lobe is not all of the lung, because it has its own body part value, it's considered a resection. Next, we have excisions for graft. So if an autograft is obtained from a different procedure site in order to complete the objective of the procedure, then a separate procedure is coded, except when the seventh character, so that is your qualifier. So if the qualifier specifies the site from which the autograft was obtained, then you're not going to code it separately. Next, we have fusion procedures of the spine. The body part coded for the spinal vertebral joints rendered immobile by a spinal fusion procedure is classified by the level of the spine. So the cervical, the thoracic, the lumbar. There are distinct body part values for a single vertebral joint and for multiple vertebral joints at each spinal level. So here's our example. The body part values, so when we say that, again, we're talking about in the PCS tables. The body part values specify lumbar vertebral joint, lumbar vertebral joints, 2 or more, and lumbosacral vertebral joints. So those are the different body part values. So the body part is coded for the joint that is rendered immobile. And then if multiple joints are fused, then a separate procedure is coded for each vertebral joint that uses a different device and or qualifier. So if it has a different device value or a different qualifier value for the two separate joints, then you would code them separately. We've got some guidelines for a combination of devices and materials, and I'm not going to read through that. You guys can take a look at that on your own. Inspection procedures. This is a good one because often when you look up in the alphabetic index, you're going to be looking up a term that ends in oscopy, and it's going to lead you to a particular table. And in some cases, it gives you the full 7 characters for your code. But what you need to know as a coder is that what was the objective of the procedure? Is it just to inspect? Because inspection itself is an integral part of any procedure that's performed. They always inspect the operative site. So you're only going to code inspection of a body part if that was all they did. So example of fiber optic bronchoscopy. So bronchoscopy, that means they did an inspection with the scope, right? If it's performed for irrigation of the bronchus, then you're only going to code the irrigation. You're not going to code the inspection. That's integral to the procedure. If you're inspecting multiple tubular body parts, the most distal body part, so that's the furthest body part, is coded. So like earlier when we talked about the deepest layers, now we're talking about the furthest. The furthest they got is what you're going to code it to. If multiple non-tubular body parts in a region are inspected, then you're going to use the body part that specifies that entire region. So the examples we have here, a cystourethropy with inspection of the bladder and the ureters is coded to the ureter body part value because that's the furthest location. An exploratory laparotomy with a general inspection of all of the abdominal contents is coded to the peritoneal cavity body part because it's the general region that they're inspecting. All right, so from here, I'm just going to kind of highlight so that you know what these guidelines include. So we have a guideline for occlusion versus restriction. We have a guideline for release procedures. We have one for release versus division. Reposition for fracture treatment is our next guideline. Then we have transplantation versus administration. We have transfer procedures using multiple tissue layers. So up here at the top, transfer procedures using multiple tissue layers. Excision, resection, followed by replacement, with some examples there. And then we get into the body part guidelines. So we start all over with the general guidelines. If a procedure is performed on a portion of a body part that does not have a separate body part value, then you code the body part value corresponding to the whole body part. Example, a procedure performed on the alveolar process of the mandible is coded to the mandible. So since they don't have a separate body part for that process, for the alveolar process, you code it to the mandible because it's a portion of the mandible. Then we've got some guidelines for when they use the term peri, when a procedure is performed on a continuous section of a tubular body part, branches of body parts, bilateral body parts. So with the bilateral body parts, in some instances, there is a body part value in the table for your fourth character that indicates bilateral. So if it indicates bilateral in the actual table, that's the value that you will select. You'll only use one code because that body part reflects bilateral. If there's not an option for bilateral, then you're going to assign two codes when the procedure is performed bilaterally. You'll assign one code for the right and one code for the left. So the example they gave is on the fallopian tubes, and because it's the same procedure on the same body part, both on the fallopian tubes, left and right, because PCS has a body part for fallopian tube bilateral, you only assign one code with that bilateral body part indicator. We've got some guidelines for coronary arteries, tendons, ligaments, bursa, and fascia near a joint, skin, subcutaneous tissue, and fascia overlying a joint, fingers and toes, upper and lower intestinal tract, and then that's it. We get into our approach guidelines. So this has to do with operative approaches. Open approach with percutaneous endoscopic assistance, percutaneous endoscopic approach with extension of the incision, external approach. So external approach, I want to touch on this one a little bit because it's not necessarily intuitive that when they do like a tonsillectomy, that's actually an external approach. So this guideline is the guideline that helps with that. It says procedures performed within an orifice on structures that are visible without the aid of any instrumentation are coded to the approach external. And so this orifice is just an opening, right? So when you open your mouth, they can look down and they can actually see your tonsils without using any instrumentation. They are completely visible. So resection of the tonsils that way is an external approach. They didn't have to cut through any layers of the body. So this is your guideline that gives you permission to code it that way, if you will. Percutaneous procedures via a device. Procedures performed percutaneously via a device placed for the procedure are coded to the percutaneous approach. So fragmentation of kidney stone performed via percutaneous nephrostomy is coded to the approach percutaneous. We have some device guidelines. One thing that I want to point out here is that you only code a device if it remains after the procedure is completed. So it tells you that if the device remains after the procedure is completed. So we're not talking about materials such as sutures, ligatures, radiological markers, and temporary post-op wound drains. Those are considered integral to the procedure and they are not coded separately as a device. So you would not select a device value when you got to your character for device. So this is the guideline that tells you such. Drainage device, a separate procedure to put in a drainage device, is coded to the root operation drainage with a device value of a drainage device. So that's a separate procedure to put in a drainage device. And that concludes the medical and surgical section guidelines. Next, we have a few guidelines on obstetrics section. It kind of gives you definitions of what the products of conception are. So when you're in there coding obstetrics section, that's something that you really have to understand, because procedures that are performed for OB, you have to know, is it a procedure that was simply performed on a pregnant female, in which case you would be coding it to some other section of PCS, versus a procedure that is performed on the products of conception. So only procedures performed on the products of conception are coded in the obstetrics section. We have procedures following delivery or abortion, some guidelines there, and then we get into some of the other ancillary section. So radiation therapy has some guidelines here about brachytherapy. We have a new technology section guideline, just some general guidelines there. And then selection of principal procedures. So I often get the question from my students about sequencing. How do you know which procedure goes first? How do you know which procedure goes second? And the rules, the general rule of thumb is that the procedure that is for definitive treatment of when multiple procedures are performed, procedures performed for definitive treatment of both principal diagnosis and secondary diagnosis, you're going to sequence the procedure that is related to that principal diagnosis first. That will be your principal procedure. If you have a procedure performed for definitive treatment and diagnostic procedures performed for both principal and secondary diagnoses, you're going to sequence the procedure performed for definitive treatment most related to the principal diagnosis as your principal procedure. So basically what this means is that it goes in order. So definitive treatment versus diagnostic treatment. So that's a hierarchy there. And your principal diagnosis versus secondary diagnosis. That's kind of a hierarchy. So first is procedures performed for definitive treatment that's related to your principal diagnosis. That will always come first. And then anything else goes second. If you have both definitive treatment and diagnostic procedures, well, the definitive treatment goes first. if you have diagnostic procedure for the principal and definitive treatment for a secondary, the diagnostic procedure is your principal, since it's most related to that principal diagnosis. So keep in mind your principal diagnosis, and things that are related to that always come first. First definitive, then diagnostic. And only if you don't have procedures that are related to that principal diagnosis would your other ones get sequenced first. And so with a lot of the coding case scenarios and stuff that you do in a classroom environment, when you're learning how to do ICD-10-PCS coding, a lot of times you're just given little snippets, because PCS is often taught completely separate from ICD-10-CM. We're really just trying to get you to have a good understanding of the code set and how to apply it. So we're not going into all the ins and outs of inpatient coding. You're not coding both the diagnosis and procedure together. So in a lot of cases, you don't even know what the principal diagnosis is. We're just giving you a little snippet of a case scenario and asking you to code it. So in cases like that, don't be concerned so much about what order you put them in. The point is just to learn how to code. So the answer to which code goes first is always going to be, well, it depends, because it depends on your case scenario. In the real world, you would have an entire inpatient admission, because remember, PCS codes are used for inpatient facility billing. So to bill the hospital services. So not the professional bill, but the facility bill. And so you're going to have the entire chart there. So you're going to know what happened to that patient throughout the entire stay. You're going to know what the principal diagnosis is. And then you're going to sequence your procedures accordingly. And sometimes you might have two procedures that are related to that principal diagnosis, and they're both performed for definitive treatment. And in that case, you can sequence them in any order. Okay. A lot of times an electronic encoder is going to help with the sequencing, because it knows which procedures may or may not affect your DRG, your MS-DRG, which is what the revenue is based on. So again, I didn't want to read through all of these guidelines verbatim. I just wanted to give you an overview of them so you know what they cover, so that you can come back and read these in their entirety, highlight if you need to highlight, make some notes if you need to make some notes, but just remember to come back to them when you're in the coding process. And what I mean by that is that, say you're coding something in the medical surgical section and it's a bypass procedure. Well, if it's a bypass procedure, then you want to stop and come over here and take a look-see at these bypass guidelines and make sure that you're following the guidelines. So that's what I mean by know what's in here and know when you need to come back and refer to these guidelines in your coding process. So I hope that helps. And with that, I'm going to go ahead and end this session. If you would please give this video a like, please follow my channel so that you'll be aware when new content comes out. I would very much appreciate it. And with that, Dr. Teal out.